We may support a different product, but one of the things that we're very strong about, well, is collaborating with each other. So there's a number of conversations between the health center controlled networks and the extension centers about being able to provide services across each other and supporting each other to support other products in their communities, because there's no point in repeating the wheel. If we can go out there and actually find somebody that's been doing an implementation for 10 years and knows that product inside and out and how to implement it in the communities, in small provider practices and larger practices, why not learn from them instead of training your staff to actually do that in-house? And so there's a great opportunity for both the health center controlled networks to work together and for the extension centers to leverage those health center controlled networks for the products they need to serve.
And then Kevin?
Well, first of all, let me say that this has been a great panel, because this has been an eye-opener, I hope, for not only ourselves but for a lot of people that are on the phone today. We've been asked several times about where are the safety net health centers and community health centers going to get these type of services and at an affordable, rate, and to see these type of organizations established that have been around for a long time providing this. I think we need to do a better job as an industry promoting the availability of these, which kind of leads into my question. How many organizations like yourselves are there out there, and do you find yourself, do you compete in certain geographical areas, or are there territories? Because I noticed as we see the maps, we see kind of counties kind of walled off of saying we've got this, they've got this. Is that kind of the way it's defined process-wise because of centers that are working with certain organizations, or are there dozens of you out there competing for various different geographies?
This is Walt Culbertson. Kevin, basically in Florida, I think that with the two main ones that we have, we very collaboratively work together. We're very much dedicated and support rural physicians, where I think HCN is very much within more of a metropolitan area. But a great opportunity, just as Paul was saying, is for us to learn from each other and share similar resources and opportunities. So I don't look at all that we compete against each other. We very much leverage each other's strengths within those communities. And I think the map that you saw was really the REC opportunity to be geographically defined. But I think that that's not so much the case with the outreach and what we do as community health center support.
Yeah, I think that is a great question, and you couldn't have picked two better people to probably address it, since we are in the same state. And as that map shows, we have health centers today in Health Choice Network that fall under the Regional Extension Center that Walt runs today. So it's, we have to work together. And the beauty of the health center controlled networks is it truly is about the health centers. Bottom line, it's about the patients, and we work together because we're all working toward the same goal. So, whether our health centers are in their regional extension center, vice versa, we work together.
And just from the national perspective, Kevin, this is Mike Lardiere. There are about 80 health center controlled networks across the country. And what I didn't provide on the map was sort of the lines and the web of where they are. So there's no geographic restriction to health center controlled networks. And I think as the panels identify, they do try to work with each other. It's really up to the provider to determine who's the better partner. And as any partnerships, it really depends on how that works out. So that works out very, very well, and it's very fluid. And we have people that reach all across the country from different places.
So yeah, I'm in the same way that Michelle is, as Paul Matthews. We have clinics that we operate or serve across 6 states. And in Oregon, we definitely are the large gorilla on the block when it comes to implementation. However, when you look in California, there's a number of health center controlled networks there. We've partnered with a number of them over the years. We've actually competed against a number of them in different regions. Because part of this is going to be is that you have a sustainability issue. How do you maintain your services? How do you sustain yourself? And part of that is competitive. However, when it comes to the final decision and actually making the right decision for the clinic, I've never bumped into an instance where somebody has been sold a product that will not meet their requirement. We are definitely about the clinics and not about providing market for the vendors themselves. So it's a very good community. We all do talk frequently. We have a lot of people that are meeting at national level, and we discuss frequently issues around sustainability, around the product lines that we serve. Around the extension centers, we are tied geographically. It's based on zip code, and so we can operate within certain zip codes. However, you can be invited in to act as a service provider or vendor to provide services in other communities. And so there's a lot of capability. If somebody wants our product, they can invite us into their community. If a clinic wants it, we will definitely go and talk to them. But a lot of this is around us vetting the clinics that want to join a health center controlled network as well. Because one of the things you have to be able to do is operate as a community asset. It's not about competing against the other clinics in your region at that point. It's about providing a continuum of care for those patients. And for the health center controlled network market, you don't want to be competing for the same patients necessarily. It's not good for the patient. And so hopefully what we'll see is that the implementations of EHRs and of HIE is about getting those patients the best possible care and service, and not about competing for market share.
And the other thing, there's so much need out there. We know there are about 800 health centers now, just in the health center world, that don't have EHRs. There's going to be about another 800 that come up with healthcare reform to meet another 20 million patient needs. So to be competitive doesn't work for anybody. A question from Art Davidson from the board. Then I want to go to one online question, and then one question internal.
Thank you, Mike, and thank you to the panel. I enjoyed hearing about your leadership, and wanted to understand a little bit more about that, maybe in line with some of the questions that Kevin was describing. So we have 3 HCCNs that are now RECs represented here, but you mentioned, Mike, that there were 80 HCCNs around the country. How many of those 80 are participating in RECs, not leading them, but participating, is the first question. The second is, among those HCCNs, it said in your introduction that 51% ownership needs to be by the community health centers. What percent of those 80 actually have non-CHCs as members, and how significant is that? Because it was good to see in your slides, Walt, about the target, about the priority PCPs out there, and trying to understand the relationship between this community good that Paul just described, and how these others in the community would look at being a part of this effort. And then the last question is, and this one came from you, Michelle, the map, and I know that the others have extension into other states. The map included Rhode Island, so we have on our board someone from Rhode Island. I want to understand how a CHC in Rhode Island that's being supported by a HCCN in Florida, given your comments, Walt, about how one Rio is different than the next, and you really don't know more than that one Rio, how there might be some tension between I'm supported by a HCCN in one state, but I'm a member of a Rio in another. And has that come up as an issue in any of your work?
I'll take that one first. We have actually run into that exact case. We have a health center controlled network in Utah that is a member of Health Choice Network. They have UHIN is the Rio there, and we're working directly with, as Health Choice Network, it's our goal to work with UHIN in Utah to get these centers what they need. I mean, ultimately it is about getting the centers where they need to be, regardless of the state they're in. As far as our member centers today, our goal, they will get to meaningful use. They'll all get to meaningful use. Whether they participate with the exchanges and whether they participate with the RECs in their area or in their state, I haven't gone into that in-depth discussion with them yet. I mean, their goal is to get to meaningful use. I think if the partnership could work, they would become part of the REC, but I think that that's probably on more of a case-by-case basis.
And then in terms of the numbers, we know there are about 27 health center controlled networks that are participating with regional extension centers. We don't know why others aren't. And there are different levels of participation as well. Some are very involved, and then some are like, well, they signed the contract, and that's as far as they went. So part of what we think we'd like to see happen is for the regional extension centers to reach out to those health center control networks, and for the networks also to reach out to them, so more of that happens. So I hope that answers that. I'd like to then take a question from the audience out online and then from internal. So there's a question from Cy Buchanan. He says he's concerned that the racial and ethnic health disparities might be exacerbated by HIT unless underserved consumers are educated about the benefits of HIT, and is wondering what is being done to address this.
Yeah, this is Walt Culbertson. Well, when you think about it, Mike, that's one of the reasons we do what we do, is to help with racial disparities. And everything that we do from support of our community health centers is for that foundation. And a big part of our opportunity most certainly is to educate those we're serving through those health centers linguistically and otherwise, making certain that they can receive that information, understand it. And again, this is, I think, a part of our opportunity going forward with not only capturing the information, better using it, and then ultimately sharing it not only with other physicians but the patient, but making certain that we've decoded that health information in a way that patients can understand it regardless of their language foundation or ethnicity, and I think that's the opportunity. So we're already doing, I think, to that person online that asked that question, we're already there. We're at the forefront of breaking down those barriers, and that, in fact, is one of the reasons we exist.
And then we have a question from the audience, David Backwis. Yeah, use one of the microphones, sure.
Check. Okay. Well, good morning. My name is David Backwis. I work for a federal agency called the U.S. Access Board. The Access Board writes design requirements for accessibility, including standards for health information technology, which we issued 10 years ago. Accessibility, as I use the term, does not mean availability, which is how it's usually used within public health. It means the removal of barriers that make it difficult or impossible for people with disabilities to use technology, such as personal health records. Now I have good news for you. Today, if you didn't know it, is the 20th anniversary of the signing of the Americans with Disabilities Act. There's actually a lot happening in town, including an event at the White House today. In relation to this, today, the U.S. Department of Justice published what they call an ANPRM. That's an Advanced Notice of Public Rulemaking on websites and services under Title II and Title III of the ADA. This will have significant impact on health information technology. So I encourage your industry to read this and submit comments. You'll have 6 months. You can go to the website ada.gov, so that's easy to remember. Things you might want to consider could include the scope of technology it might apply to, the scope of providers it might apply to, how it might apply to existing technology. I'm a little disappointed that the horse is out of the barn already. A lot of you have bought the technology, but this will be around forever, so apply it to the next iteration, if nothing else. But new content is added to websites every day, so we'd have to think about how it affects day-to-day operations as well. So it was really just a comment, not a question, although I suppose one question might be whether this board would consider holding a forum specifically focused on accessibility. I could provide you with a line of panelists just for that, and the industry might need that help so that we can begin collaborating more closely. Thank you.
Great, thank you very much. Any comments from anyone on that?